Welcome to Learn Medicine by Dr. Nikita, and today we'll be learning about loop diuretics. So whenever you hear the word diuretics, one thing comes up to the mind that we are talking about a drug which is responsible for removing excessive water from the body in the form of urine. So it's a common phenomena that water is lost from the body in the form of urine, but whenever there is an excessive accumulation of water, then this process has to be triggered. And to increase the volume of water in the urine, there is a drug which is administered in cases of medical conditions. This category of drug is called as loop diuretics. So when I say loop diuretics, that means you can clearly identify this drug is targeting the loop region. So now there is a figure here, and now let's quickly look into this picture. This is a picture of a nephron, and around 1 million nephrons are present inside the human body when we talk about a kidney. So a kidney has around 1 million nephron. And what is the structure of a nephron? This is the glomerulus region and the Bowman's capsule. This is the PCT, that is proximal convoluted tubule. And this is the loop of Henle region. The loop of Henle. The loop of Henle has two regions. One is the descending loop of Henle and one is the ascending loop of Henle. The ascending loop of Henle, that is this region, is a thicker region in comparison to the descending loop of Henle. I am writing D and A, right? Then this is DCT, which stands for distal convoluted tubule, and this is the collecting duct, or CD, collecting duct. So this is a general diagram of a nephron. So initially I'll show you how the normal physiology of urine is being formed in a very quick revision, because we already posted a video of urine formation. You can check out the previous video. And then we'll talk about how the loop diuretic works. So the blood is entering and leaving through afferent and efferent arteriole, and this is how the nutrients are being escaped as filtrate, right? As filtrate. And there are a lot of minerals and water which enter this region and they pass through PCT, and now when they enter through the descending loop of Henle, here initially the fluid is isotonic, right? What is it? It is isotonic. Isotonic means it is equal in osmolarity in comparison to the fluid present here in the interstitial region and the fluid present in the lumen region. Both have equal osmolarity. But while it enters into the descending loop of Henle, there are squamous cells present here. There are squamous epithelial cells present here. Squamous epithelium cells present here, and they are allowing easy exit of water. So they are open to exchange of water molecules, and the water can easily be absorbed here, right? Or water can easily be lost here. And in the second region, when I talk about the ascending loop of Henle, that is this thick region, here what happens, this is not allowing the entry or exit of water because the cells here are very compactly present. These cells are called as cuboidal epithelium. Cuboidal epithelium. So the cuboidal epithelium cells, they do not allow the exchange of water molecules, but we do have co-transporter molecules present here. We have co-transporters. These co-transporters allow the exchange of sodium, potassium and chloride like ions, also calcium and magnesium, through the paracellular spaces. So they are tightly packed, but they do have paracellular spaces, and through these paracellular spaces, the ions can easily exchange. So sodium, potassium, chloride, all these ions can easily move out with the help of co-transporters which require energy. So we have ATPase pumps, and how is this energy being generated? The thick ascending loop of Henle here has a lot of mitochondria. It is rich in mitochondria. So this mitochondria generates a lot of energy, and that energy is utilized by these co-transporters for triggering the sodium-potassium-chloride co-transporter pumps, and they allow the exchange of ions into the interstitial fluid region, and this is how easily the ions are lost here, right? And then water moves up here, and through the collecting duct it is formed as urine. So this is the normal physiology. So now let's talk again about a descriptive diagram here. It gets a little bit complicated, so I am only focusing on the loop of Henle now. So if I draw the diagram of loop of Henle, it is thin here, and then this thin loop becomes thick. So we have to focus on this region because we are talking about loop diuretics. This is the loop of Henle. So what happens normally? That through the paracellular spaces, I was talking about they are tightly packed. So through the paracellular spaces, there is an easy exchange of sodium, potassium, and chloride, right? So all of them can easily cross this channel. All these three ions can easily move out here. So when I say these ions are easily leaving this space, there is a decrease in the ionic concentration in the blood and they are being reabsorbed. So this is the normal phenomena, how the ions are reabsorbed back into the blood, right? And this is how it reduces the loss of ions in the form of urine. Had these ions stayed in the thick ascending loop of Henle, they would have escaped through the collecting duct in the form of urine. But these ions are reabsorbed, right? This is how the ionic concentration is restored back into the body, and we have substantial amount of sodium, potassium and chloride concentration inside the blood, and these useful ions are not lost through the urine. Initially through the filtrate, they were a part of the filtrate, but they were reabsorbed through the process of co-transporters, right? So now what happens when these ions are lost, this potassium is again absorbed back through the potassium ion channel. This is a potassium channel. They are reabsorbed here, and now this becomes rich in the positive ion, this becomes rich in the negative ion. Two chloride ions are escaping here, and there is reabsorption of potassium. So when potassium gradient is higher here, the fluid inside the ascending loop of Henle is now electropositive, right? It is electropositive, but the interstitial fluid here is rich in the negative ionic concentration, which makes the fluid here as electronegative. So did you get this point? There are two chloride ions which are leaving. Sodium ion, potassium ion and two chloride ions are leaving, but the potassium ion are reabsorbed. They are reabsorbed with the help of the potassium ion channel, which makes the fluid inside the ascending loop of Henle as electropositive, right? But there is an excessive loss of chloride ions, which makes the fluid inside the interstitial fluid as electronegative. So to cope up with that balance, initially it creates a case of electrical gradient. It creates a case of electrical gradient, and to balance out this excessive negative in the interstitial fluid, there are two ions which are leaving to balance out this negative environment present here, this negative charge here. And now to cope up with that, what is leaving? Calcium and magnesium. These ions are leaving the space to balance out the negative here, to balance out the electronegative negativity inside the interstitial fluid. Now there is a balance. So now calcium and magnesium is also escaping from the fluid present inside the ascending limb, and this is how the body is now reabsorbing these ions: sodium, potassium, chloride, magnesium, calcium, and ultimately water. So these are the ions which are reabsorbed in the loop region, and this is how these ions are not lost excessively through the urine. Had they not been reabsorbed, they would have easily moved from here to here to here and through the urine. But they are reabsorbed through what process? They are reabsorbed through because of the activation of the sodium-potassium-chloride ion channel. This co-transporter allows the escape of sodium and potassium here and chloride, but the potassium is reabsorbed, which creates an electropositive environment here and electronegative environment here. To balance out that, calcium and magnesium are flowing inside, and this is how all these ions are being reabsorbed. So little potassium is reabsorbed, rest is still present here. So I'll just rub this off, and this is how we know these ions are reabsorbed. Okay. So I'll make the point clear to you again. If I again draw this, the thinner limb, and why do we have to draw this? Because now we'll be talking about the mechanism of action of loop diuretics. So this is what I was talking about. The squamous cells, and these are the cuboidal. Okay. So now what is happening with the loop diuretics? So when I see about the initial physiology where the normal urine formation process was taking place, there was an isotonic solution present here, but then the ions were escaping. Okay, the ions were escaping and there was a hyperosmolarity condition here. So when there was a hyperosmolarity by the reabsorption of sodium, potassium, chloride, calcium and magnesium, because of that there was a hyperosmolarity condition present in the interstitial fluid. This led to the reabsorption of water to balance out this hypotension and to balance out this hypoosmolarity and the hyperosmolarity. So this is how the water was reabsorbed into the blood. This is how the water was reabsorbed into the blood, and this prevented the excessive loss of water from the body. But in case of loop diuretics, we exactly need the opposite of that. Loop diuretics are useful in conditions of renal failure. They are useful in conditions of hypertension. They are useful in conditions of pulmonary edema. They are useful in conditions of peripheral edema. They are useful in conditions of hypertension we already talked about. So few of these conditions, right? So in these cases, we require the use of loop diuretics because they are responsible for throwing out excessive amount of water which is stored in the body, that and also in cases of cardiac failure. So we require excessive amount of water to be thrown out from the body because these conditions are responsible for they are causing critical cases. Excessive water retention is not required by the body, and if that is the case, we require to throw that excessive water in the form of urine. So we need to stop this reabsorption of water. That is the main function of loop diuretics. It will stop the reabsorption of water into the blood because this excessive reabsorption of water, which was due to these ions, will create an increased volume of water inside the body. The water will be inside the body because of the reabsorption through the blood into the blood, and this will lead to certain conditions. So in these conditions, we require a loss of water from the body. And how do we do that? One classic example, when I was already talking about the co-transporter. So here is the co-transporter, sodium-potassium-chloride co-transporter. This ion channel is blocked by loop diuretics. So this is the targeted site of loop diuretics. They block the sodium-potassium-chloride co-transporter, and when that is blocked, there is no escaping of sodium, there is no escaping of potassium, there is no escaping of chloride. And when there is no escaping of all these ions, then there will be no electrical gradient developed. So there will be no escaping of calcium and magnesium. So none of these ions will escape, and all these ions will remain in the ascending loop of Henle, that is the thick loop of Henle. And when all these ions are present inside this region, they will become a part of urine and they will be lost from the body. Along with that, it will reverse this scenario of hyper and hypoosmolarity. And now, when all the ionic concentration is there inside the ascending loop of Henle, so the blood will now become hypoosmolar, and inside the nephron we'll have hyperosmolarity. And when there will be hyperosmolarity, it will draw the blood. It will draw the water from the blood, and more water will be reabsorbed to balance out this osmolarity condition, and excessive water will be reabsorbed, and along with all these ions there will be an increased amount of water in the urine, and more amount of water will be lost, which is the main primary function of loop diuretics. So loop diuretics can actually release up to 10 liters of urine when they are administered. So there are three popularly known loop diuretics. One is furosemide, one is bumetanide, and third is toracemide. I'll write down their names. I'll just remove this one. So there are three popular loop diuretics: furosemide, bumetanide, and toracemide. So these are the three popular loop diuretics, which are strong diuretics, and that loop diuretics are very strong in action. When given through intramuscular route, they start to function in 10 to 20 minutes. When given through IV route, 5 to 10 minutes is their onset of action time. And when given through oral route, 20 to 40 minutes is their onset of action. Their action usually lasts for 3 to 6 hours, and their bioavailability is 60% when orally given. When orally given, their bioavailability is 60%. And these drugs are always, whenever you consult a medical practitioner or whenever a person is being administered a loop diuretic, they will always suggest that this drug has to be given in the daytime. And why do we need to give this in the daytime? Because you do not want to disturb the sleep cycle of a person, of a patient, specifically the patients we mentioned recently, the renal patients, the hypertensive patients, the peripheral edema patients, the pulmonary edema patients, the cardiac patients. So they are administered in the daytime to avoid the disturbance in the sleep cycles. And yeah, that is this. And then talking more about the loop diuretics, one primary function, their exact mechanism is hitting the sodium-potassium-chloride ion exchange pump, and that is all. This is how all the ions are not lost in the blood, are not reabsorbed in the blood, and therefore lost in the form of urine. So basically your body is losing all these ions. So there are few contraindications also, few side effects also, which are, I'm just have this visible. So they are hypokalemia, hypovolemia, dehydration, hyponatremia, and then, so these are few of the side effects. Excessive loss of hypocalcemia. So excessive loss of potassium, excessive loss of sodium, excessive loss of calcium, excessive loss of water can lead to these conditions, and excessive loss of extracellular fluid. So these are the conditions which are developed, which are side effects of loop diuretics. And in addition to that, these drugs also trigger gout in patients. One more side effect of this drug is damage to the inner ear, or we can also call it as ototoxicity. Okay. In short, loop diuretics are targeting the loop of Henle of the nephron In the loop of Henle, they are blocking the sodium-potassium-chloride co-transporter pump, which is responsible for the exchange of these ions, which is responsible for the reabsorption of these ions into the blood, but they are prohibiting that, and due to that there is no electrical gradient which is being developed, which leads to retention of these ions inside the nephron, and because of that they are now a part of urine, and all these ions are lost in the urine. When the ionic concentration inside the nephron is high, this leads to excessive absorption of water from the blood to the nephron, and now more volume of water is present inside the loop of Henle, and this leads to addition or increase in the volume of urine, and a heavy amount of water is lost along with all these ions, which develops to these conditions, or I would say that it is also responsible for treating conditions like edema, treating conditions of hypertension, treating people with heart failure. So yeah, it has its pros and cons. So thank you for today's lecture. And what I'll suggest is next topic I'll take up a different kind of a diuretic, and this is how we'll proceed by learning about mechanism of actions of different drugs in next lectures. So do like, share, and subscribe, and follow all the social media platforms on Instagram, on Facebook, and YouTube. Thank you.